Welcome to the Explainer. So, today we are tackling a subject that, let's be honest, gives medical billing departments a massive headache, and that is arthroscopic knee surgery. I mean, look, while these procedures are absolutely incredible for patients, the complex web of CPT codes behind the scenes, yeah, that can be incredibly tough to navigate. But don't worry, our goal today is to completely demystify these rules and make sure you understand exactly how these codes work together to accurately reflect the knee surgery procedures being done arthroscopically.
Okay, let's dive right into this. On our agenda today, we'll look at the overarching billing challenge and then break down 4 key codes: diagnostic arthroscopy, lavage, lateral release, and removing loose bodies. And finally, we'll wrap it all up with a quick summary.
Section 1. The Arthroscopy Billing Challenge.
So, this really brilliantly illustrates the core tension here. On the left side, we see the patient experience. Arthroscopic knee surgery allows orthopedic surgeons to inspect the inside of the joint and make repairs without open surgery, right? It means small incisions, diminished post-operative pain, a really fast recovery. I mean, it's typically an outpatient procedure. It's fantastic for the patient. But look over at the right side. The practice experience is a whole different story. Because multiple procedures can be done arthroscopically during a single surgical encounter, payers, and we're looking especially at Medicare here, put strict limits on the number of services they'll actually pay for on the exact same calendar day.
Which brings us to this highly critical piece of advice. Practices should check Medicare's National Correct Coding Initiative or the NCCI policy manual and code edits to stay on top of these limits. Look, if you ignore these edits, you're going to face claim denials. It's a guarantee. You have to understand these bundling rules to avoid those endless rejections and successfully capture the revenue your practice has rightfully earned.
Moving on to Section 2, Diagnostic Arthroscopy, Code 29870.
All right, here is the fundamental definition you really need to commit to memory. Code 29870 is the base, or the parent code, and because of this, it is inherently included as an unbillable component in all other knee arthroscopy procedures. You can kind of think of it like a cover charge at a venue, right? The moment you actually perform another, more specific repair procedure during that same surgical encounter, the cover charge of simply looking around with the arthroscope gets entirely absorbed.
So, the absolutely crucial point here is this. Code 29870 would be reported separately only when it is the absolutely singular procedure performed. If the surgeon goes in, takes a look, diagnoses the issue, and then decides to close up without doing any other repairs at all, well then, and only then, can you bill 29870 all by itself.
Section 3. Lavage. Code 29871.
Lavage, under Code 29871, describes a procedure where the surgeon actively flushes the joint with saline. It's this fantastic, really direct way to physically wash out the area to treat an infection or manage severe arthritis. It's a highly beneficial procedure that actively improves the patient's condition right then and there on the operating table.
But here is a question for you to consider. Why do payers so heavily scrutinize this specific code? I mean, honestly, sometimes it feels like payers are acting like true crime detectives, dusting for fingerprints every single time you submit a 29871 claim. Why the intense magnifying glass?
Well, the answer is due to historical misbilling. Because of some issues in the past, payers are always on high alert when they see a lavage claim come across their desk. If you are reporting this, you must make absolutely certain that your diagnosis codes firmly and clearly support the procedure. There's really no room for ambiguity here. The medical necessity absolutely must perfectly match the code to get this claim approved.
Let's move to Section 4 and see how this builds. Lateral release, Code 29873.
Now, this code involves some very specific anatomy. Lateral release describes precise work done in the patellofemoral compartment of the knee. The specific goal of this procedure is to treat a misalignment of the patella, the kneecap, which is typically caused by tightness of the lateral retinaculum. By releasing that tight tissue, the surgeon essentially gets everything aligned properly again. However, you have got to read your operative reports and your CPT code descriptions very, very carefully on this one. Code 29873 is not separately reported if it's performed alongside a reconstruction or repair code, whether that's open or arthroscopic, and that repair code's description expressly states it includes lateral release. If those words are in the bundled description, your 29873 code just gets completely swallowed up. You simply cannot bill it twice. Section 5. Removing loose bodies. Code 29874. So Code 29874 describes the removal of loose or foreign bodies. We are talking about things like osteochondritis dissecans fragmentation or chondral fragmentation. Now, I know loose bodies sounds a bit like the title of a late-night true crime show, but in orthopedics, it's just a routine issue. Here is the catch, though. Generally speaking, this removal procedure is considered inherent to other procedures performed in the exact same knee compartment, meaning, you guessed it, it is not separately billable.
Now, what's really interesting about this slide is the explicit exception to that rule. The CPT manual dictates strict physical requirements to actually bill 29874 separately. You don't just get to claim it. The surgeon has to provide physical proof in the operative notes. The loose or foreign body must be the same size or bigger than the diameter of the cannula used for the main procedure. And in order to get it out, the surgeon must physically place a separate, larger cannula or make a separate incision or purposely enlarge the portal. If those specific anatomical and physical steps aren't documented, you do not get to bill it separately. No way around it.
Finally, Section 6, Summary and Conclusion.
All right, here is your ultimate cheat sheet. Let's cement these rules really quickly. For 29870, the diagnostic procedure, it is billable separately only if it's performed completely alone. For 29871, lavage, yes, you can bill it, but it requires a very firm supporting diagnosis due to high payer scrutiny. For 29873, lateral release, it is not billable separately if it's already included in the description of a bundled repair code. And finally, for 29874, loose bodies, it is only billable if those strict size and incision criteria are clearly met and documented. And this brilliantly illustrates why you need absolute meticulous precision in your coding. The rules are strict and the documentation must match perfectly.
Which brings us to our final thought for today. Are your practice's coding habits leaving hard-earned surgical revenue on the table? These rigid NCICI limits are a daily reality, for sure, but they shouldn't negate the intense surgical labor your providers are performing during these complex procedures. By understanding these precise rules, knowing exactly when to bundle, and exactly what physical exceptions allow for separate billing, you can protect your practice. So stay vigilant, scrutinize those operative notes, and ensure every single arthroscopic procedure is captured correctly. Thanks so much for exploring this with me today, and keep mastering those codes.